The pancreas, named after the Greek words pan, meaning all, and krias, meaning flesh, is a soft lobulated organ that measures 12 to 15 centimeter long and is located in the retroperitoneal space. It sits behind the stomach and spans the L1 L2 spine in a J shape. When it comes to its location, the head of the pancreas is in front of the L2 vertebra, the body is in front of the L1 vertebra, and the tail extends to the level of the T12 vertebra. Remember, the neck of the pancreas is quite delicate, and trauma to the lumbar spine, especially at the L2 vertebra, can cause trouble. In acute pancreatitis, the lesser sac is the most common site of fluid collection or pseudocyst formation. The proximity of the posterior wall of the stomach to the anterior wall of a pancreatic pseudocyst in the lesser sac is what makes cystogastrostomy possible to treat pseudocysts. Let's understand the anatomical relationship of the pancreas with other neighboring organs. Now you must ask yourself why you would need to know this relationship. How can anatomy help me understand internal medicine? The answer lies in the approach. Let me explain. The pancreas has 5 sections: the head, uncinate process, neck, body, and tail. The head makes up half of the pancreas, with the body and tail accounting for the other half. Positioned at the duodenal C loop, the pancreatic head is located in front of the inferior vena cava and left renal vein. This is why pancreatic head cancer can cause gastric outlet obstruction by compressing the duodenum. The uncinate process is an extension of the lower half of the head that is between the superior mesenteric artery and vein in the front and the aorta behind. The terminal part of the common bile duct runs behind the upper half of the head of the pancreas before joining the main pancreatic duct of Wirsung. These two structures form an ampulla that opens at the papilla on the medial wall of the second part of the duodenum. That's why a mass at the pancreatic head will compress the common bile duct early in the disease process, with obstructive jaundice as one of the symptoms. The neck of the pancreas, in front of the junction of the splenic vein, superior mesenteric vein, and portal vein, serves as the arbitrary junction between the head and the body of the pancreas. Now listen carefully. Pancreatic pathologies can cause splanchnic venous thrombosis, with the splenic vein being the most common site. The body and tail of the pancreas rise obliquely up to the left in front of the aorta and left kidney. The narrow tip of the tail of the pancreas reaches the splenic hilum in the splenorenal ligament. This means that during splenectomy, the tip of the pancreatic tail at the splenic hilum is susceptible to injury. Due to the proximity of veins and arteries, inflammation of the pancreas puts the patient at risk of pseudoaneurysm formation, resulting in GI bleeding, abdominal compartment syndrome, and splanchnic venous thrombosis. Now let's understand the pancreatic duct system. The pancreatic duct is located in the bottom part of the head, extending from the end of the pancreas to the head. There, it unites with the duct of the uncinate process and then with the lower part of the common bile duct to form a hepatopancreatic ampulla. This ampulla runs through the medial wall of the middle of the second part of the duodenum and opens on the dome of the major duodenal papilla. Here, pancreatic secretions mix with bile and are dumped into the duodenum. But what controls the smooth functioning of this process? What keeps bile from going into the pancreatic duct, pancreatic secretions into the biliary tree, or even worse, duodenal contents into the pancreas and biliary tree? Any of these scenarios can be disastrous. To avoid the reflux of duodenal secretions into the pancreatic and common bile ducts, a smooth muscle sphincter of OD encircles the common channel of these two ducts. Before the pancreatic duct joins the common bile duct, a separate muscle sphincter also surrounds the end of the primary pancreatic duct, preventing bile from refluxing into the pancreatic duct. Similarly, a sphincter encircles the lower part of the common bile duct, preventing the reflux of the pancreatic juices. Now, the upper part of the head of the pancreas is drained by an accessory pancreatic duct that opens into the duodenum at the minor duodenal papilla, which is 2 cm anterosuperior to the major papilla. The two pancreatic ducts often communicate with each other. Embryology is the original Netflix series of your life. Season 1, Womb Chronicles. Now let's focus on the embryological development of the pancreas. Two buds, one large and one small, grow from the primitive duodenum at the point where the foregut and midgut meet to form the pancreas. The inferior part of the pancreatic head and uncinate process originate from the ventral bud, while the superior part of the body, head and tail arise from the dorsal bud. As the stomach undergoes a 90-degree clockwise rotation during embryonic development, the left side of the gut tube faces anteriorly and the right side faces posteriorly. Due to this rotation, The duodenum takes on its characteristic C-shaped configuration and becomes mostly secondarily retroperitoneal. The ventral pancreatic bud moves to the back and merges with the dorsal bud. As the duodenum swings to the right, the distal duct of the dorsal bud combines with the duct of the ventral bud to create the main pancreatic duct. The common bile duct, which comes from the ventral bud, fuses with the main pancreatic duct to create a common channel. The accessory pancreatic duct is the remaining proximal part of the duct of the dorsal bud. Now let's understand anomalies that can disrupt the normal developmental process and give rise to conditions with significant clinical implications. Specifically, we will focus on the pancreas divisum, anomalous pancreatico-biliary junction, also known as APBJ, annular pancreas, and circumportal pancreas. Let's begin with pancreas divisum, a condition where the primitive ducts of the ventral and dorsal pancreas fail to merge. This results in the larger dorsal pancreas draining through the accessory pancreatic duct into the second part of the duodenum at the minor duodenal papilla. Individuals with this condition rely on the accessory duct for primary drainage of exocrine secretions. The patients may have poor sphincter functionality at the minor duodenal papilla, leading to intraductal stasis of pancreatic secretions. Pancreatic secretions from the head and uncinate process continue to drain through the major duodenal papilla. Moving on to anomalous pancreatico-biliary junction or APBJ, a rare anomaly where the main pancreatic duct and common bile duct converge before entering the duodenum. Without the usual support from the hepatopancreatic ampulla of water, the sphincter of Oddi may be malformed, allowing for reflux into the pancreas and biliary tree. APBJ patients are at an increased risk of either pancreatico-biliary reflux, that means from the pancreas towards the biliary tree, or biliopancreatic reflux, that means from the biliary tree to the pancreas. If the reflux is pancreatico-biliary, it can increase gallbladder and biliary amylase levels, increasing the risk of biliary tree malignancies. Our next stop is the annular pancreas, a condition that can arise from the growth of a bifid ventral pancreatic bud around the duodenum, forming a pancreatic ring. It can also occur if the ventral or dorsal pancreatic buds fail to rotate correctly. Inflammation in the annular pancreas can lead to duodenal blockage, seen as the double bubble sign in imaging studies. Neonates with annular pancreas often have associated conditions like tracheoesophageal fistulas and congenital heart defects, which are sometimes linked to aneuploidies like Down syndrome. Notably, pancreatico-biliary neoplasms are more prevalent in patients with an annular pancreas. Finally, we'll explore the circumportal pancreas, an annular variant where pancreatic tissue surrounds the portal vein or its tributaries. This anomaly is thought to occur when the developing uncinate process fuses with the pancreatic body tissue, entrapping the portal venar confluence. Now let's shift our focus to the clinical aspect of how the pancreas embryology help us understand the location of the pain in pancreatic pathology. The pain of pancreatic origin in conditions such as acute pancreatitis, chronic pancreatitis, and pancreatic cancer is typically felt in the epigastrium because it is a foregut organ and radiates to the back because the pancreas is a retroperitoneal organ. Before discussing the radiology of the pancreas, remember that the head of the pancreas sits in the front of the L2 vertebrae. The body is in front of the L1 vertebrae and the tail extends to the level of the T12 vertebrae. This means that a single CT scan cut section cannot fully capture all the aspects of the pancreas. When evaluating the pancreas, a gold standard approach involves utilizing a triphasic contrast enhanced CT scan with the three-dimensional triplanar reconstruction. This imaging techniques provides detailed insights into the pancreas by capturing axial, coronal, and sagittal planes. Always remember, understanding the normal is the prerequisite to identify the abnormal. So, what is the expected diameter of the pancreatic duct in a healthy pancreas? The average diameter of the pancreatic duct in the head is 3 to 4 mm, while in the paroxysmal body, it is around 2 to 3 mm. Now, let's go beyond the visualization of the pancreas. I'm talking about endoscopic ultrasonography or EUS. This technique involves mounting an ultrasonographic probe at the tip of an upper gastrointestinal endoscope and passing it into the duodenum second part. Through EUS, we can visualize the pancreatic head, distal regions of the pancreatic ducts, intrapancreatic area of the common bile duct, and even the pancreatico-duodenal lymph nodes. It offers real-time imaging, high resolution, and the ability to perform fine needle aspirations, enabling us to obtain tissue samples for further analysis of pancreatic pathology. Now let's understand the vascular supply of the pancreas. As you know, the pancreas originated at the junction of the foregut and midgut, so it derives its blood supply from the vessels supplying the foregut and midgut, the celiac and superior mesenteric artery respectively, with collaterals between them. So when addressing bleeding associated with pancreatitis or pancreaticoduodenectomy through angiography, it is crucial to evaluate both the celiac trunk and superior mesenteric artery. It is vital to know the origin of the celiac trunk and superior mesenteric artery to perform any surgical or interventional procedure. The celiac trunk originates from the anterior surface of the aorta at the level of T12 and L1, while the superior mesenteric artery branches off just below the celiac trunk at the level of L1, situated behind the neck of the pancreas. When it comes to venous drainage of the pancreas, the head of the pancreas drains into the superior mesenteric and portal veins, whereas the body and the neck of the pancreas drain into the splenic vein. The pancreas is rich in an intricate network of lymphatic vessels. Those from the body and tail drain into the splenic lymph nodes and subsequently into lymph nodes in front of the aorta between the celiac and superior mesenteric arteries. The head and neck lymphatic vessels take a different route, draining into the lymphatic vessels around the pancreaticoduodenal, mesenteric, and hepatic arteries before reaching the lymph nodes in front of the aorta. Understanding this vascular and lymphatic anatomy is critical, particularly in pancreaticoduodenectomy. This surgical procedure is required for the resection of the pancreatic head and periampullary cancers. If infiltration of the superior mesenteric vessels and or the portal vein occurs, the pancreatic malignancy is considered unresectable. Shifting our focus to neural supply. Parasympathetic nerve fibers to the pancreas originate from the posterior vagal trunk via the celiac branch. On the other hand, sympathetic supply comes from T6 to T10 and the celiac plexus through the thoracic splanchnic nerves. I will discuss the clinical implication of the neural supply when we understand the exocrine and endocrine function of the pancreas. Human body is a complex system that is built upon the architecture of anatomy and infused with vitality by physiology. In this context, it's important to understand the role of the pancreas and its clinical implications. The pancreas is a unique organ that is both exocrine and endocrine. The fundamental difference between the two is that exocrine glands secrete substances into a ductal system to an epithelial surface, whereas endocrine glands secrete products directly into the bloodstream. The exocrine pancreas is organized into a network of ducts and acinar cells that form lobules, which make up to 98% of the pancreatic tissue. So what about the remaining 2%? This 2% of the pancreas is dedicated to endocrine tissue. The endocrine tissue is crucial in producing hormones, specifically insulin and glucagon, whereas exocrine tissue produces enzymes for carbohydrate, fat, and protein breakdown, facilitating efficient absorption during digestion. Enzymes like amylases, lipases, deoxyribonucleases, and ribonucleases are active enzymes, whereas trypsinogen and chymotrypsinogen are proenzymes, requiring entropeptidase from the duodenum to activate trypsinogen to trypsin, and trypsin then activating the rest of the enzymes for protein breakdown. This means that the pancreas must have a trypsin activator silencer to prevent self-digestion, which is called a pancreatic trypsin inhibitor. In addition, our blood has alpha-1 antitrypsin, which inhibits neutrophil elastase. But you do not need to worry about that for now. We will cover it in detail in upcoming emphysema and cirrhosis lectures. These enzymes are produced in the endoplasmic reticulum packaged in the Golgi apparatus and reside in the zymogen granules at the apical pole of acinar cells. These enzymes need an alkaline environment for efficient activity. So ductular epithelial cells secrete alkaline and isotonic fluid, which we will study in detail soon. Now that we know what the pancreas secretes, let's take a closer look at who control this crucial organ. Understanding this will also shed light on the clinical implications of the neural supply of the pancreas. The pancreas secretes enzymes and fluid at a baseline rate during the interdigestive period. This steady flow is linked to the intestinal migratory motor complex, or MMC, which is regulated by the parasympathetic nervous system and the hormone cholecystokinin, also known as CCK. During mealtime, the pancreas increases its juice secretion up to 20 times the baseline rate. This process occurs in three interconnected phases: the cephalic, gastric, and intestinal phases. In the cephalic phase, vagal nerve stimulation of both pancreatic acinar and duct cells is triggered by the mere anticipation, sight, smell, taste, or mastication of food. This reflex action is mediated by acetylcholine acting on muscarinic M3 receptors in acinar and duct cells. Additionally, gastrin released into circulation due to vagal activity in the gastric antrum contributes to pancreatic enzyme secretion by acting on CCK-A receptors on acinar cells. Parasympathetic stimulation increases pancreatic secretions, whereas increased sympathetic splanchnic nerve activity reduces pancreatic secretion. Moving to the gastric phase, both neural and hormonal components stimulate the pancreas. Distension of the stomach triggers the gastropancreatic reflux, activating stress receptors that transmit information via afferent nerves in the vagus to the medulla. Efferent vagal nerves are excited, promoting a vasovagal reflex to the pancreas through the neurotransmitter acetylcholine. Simultaneously, gastrin released in response to protein digestion products further stimulates pancreatic acinar cells. The intestinal phase is organized by hormones such as CCK and secretin, as well as the enteropancreatic vasovagal reflex. CCK synthesized in the duodenal mucosa is released in response to lipids, amino acids, and peptides, but not to carbohydrates or hydrochloric acid in the chyme. Secretin, synthesized in the duodenal mucosa, responds primarily to hydrochloric acid in the chyme. Secretin enters circulation and stimulates bicarbonate and fluid secretion in pancreatic duct cells. Once the meal is over and the alimentary canal no longer contains stimulatory factors, the pancreatic function returns to a baseline interdigestive state. As a backup, intestinal cells release peptide YY, a potent inhibitor of pancreatic enzyme secretions in the presence of fat in the terminal ileum and colon. We now understand the part that neurohormonal agents like acetylcholine, gastrin, and cholecystokinin play in the pancreas. But how do they exert their influence? To get to the bottom of this, we need to delve into the biochemistry of the pancreas. I know biochemistry isn't the most exciting topic, but it's like the broccoli of science. You might not love it, but you need it to grow. When these agents stimulate the pancreas, it triggers a surge in the concentration of intracellular calcium ions, which initiates exocytosis. During exocytosis, zymogen granules fuses with the apical membrane of the acinar cells, releasing enzymes including amylase, lipase, and proteases into the acinar lumen. The next step is the release of isotonic fluid, which helps transport enzymes into the ducts. Interestingly, the flow rate of the pancreatic secretions can alter the fluid's composition, changing it from chloride rich at low flow rates to bicarb rich at high flow rates. So, how does this happen? The elevated calcium concentration caused by stimulants activates protein kinases, which in turn open chloride ion channels in the apical membrane. Chloride ions move from the cytoplasm into the acinar lumen, while potassium ions diffuse out of the cell through basolateral membrane channels, inducing hyperpolarization, amplifying the driving force for chloride ions to exit the cells. The sodium-potassium chloride transporter at the basolateral membrane maintains the diffusion gradient for the chloride anion, which is driven by the sodium gradient established by the sodium-potassium pump. Furthermore, the electronegative lumen attracts sodium ions, propelling them through the cationic channels in the tight junctions between the adjacent acinar cells. Resulting osmotic change draws water into the duct system, creating an isotonic secretion. As the flow rate increases, bicarbonate becomes the predominant ion, leading to a reciprocal change in chloride concentration. The bicarbonate in the duct cells comes from two sources. It's either transferred from the interstitial fluid using the sodium bicarb cotransporter, or it diffuses from the interstitial fluid. Carbon dioxide is a lipid-soluble gas that diffuses into the cells, where it reacts with water in the presence of carbonic anhydrase to produce carbonic acid. Carbonic acid dissociates to produce H positive and bicarbonate anion. The basal secretion of bicarbonate from the ductal cells is accounted for by the action of an anion exchanger in the luminal membrane. This mechanism transports bicarbonate from the cell into the lumen in exchange for chloride uptake. Chloride moves down its concentration gradient into the cell. When duct cells are stimulated with the hormone secretin, it enhances bicarbonate secretion. Now we will use these concepts to build your understanding of pancreatic pathologies so that it is easier to remember them for exams and for patient care. So stay tuned for upcoming lectures on acute pancreatitis, chronic pancreatitis, and pancreatic malignancies. With this thought, I will take your leave until we meet again. If you like this video, please like, share, and subscribe to our channel. Read well, revise more, aim high.